Thanks again for the invitation to come speak. It's always an honor to be here and give various different lectures. These are my disclosures. They don't have any conflicts with the content in this talk. So scoliosis, as you can see, in the adult population is common. In volunteers over the age of 60, 68% had some evidence of scoliosis. So as you can see, with an aging population, and as the aging population increases over time, we're going to see more and more scoliosis. So this is one of the most important papers in spine surgery and by Glassman, correlating radiographic measures of deformity with patient-based outcome, and this is an important aspect in the management of patients with scoliosis. And for the first time, we've actually been able to show that positive sagittal balance was the most reliable predictor of clinical symptoms, and just a very important thing that we have to always keep in mind when planning on how to treat patients with scoliosis. So these are just figures from that paper showing the correlation with the positive sagittal balance and the health-related quality of life measures. So so we all are familiar with the clinical presentation of degenerative scoliosis. It's not the same as idiopathic. Very often, degenerative scoliosis, there are more symptoms that are associated with stenosis. And so this is going to be more aggressively progressive in comparison to idiopathic scoliosis. Idiopathic scoliosis might not progress very rapidly, whereas degenerative scoliosis can progress at a rate of about 4 degrees per year if you follow it. So important to distinguish between the two. And there are a variety of radiographic features. One of the most important things to assess in the older population or the adult population is the degree to which the curve is stiff. And for this reason, x-rays become very important. In addition, all of the different subluxations and spondylolisthesis, olesthesis, all of these are things that need to be assessed on imaging. So, there are a variety of surgical indications for the treatment of adult scoliosis, as we all know. And there are factors that may modify what we plan for each individual patient, including whether or not they have osteoporosis, cardiopulmonary disease. We have to assess to what degree they have frailty. All of these are things that may either influence us to pursue surgery or not, or to change the nature of the surgery involved. And so very important to use x-rays, because not only are they simple, but they give us a real visualization of what the patient's anatomy is like in the standing position and as well as in the dynamic position. And so, so dynamic studies are critical to know what kind of correction you can achieve just simply from positioning. So, and bending films as well provide similar information with regard to the flexibility of the curve. So these are the radiographic drivers of disability, and we're familiar with the relationship of lumbar lordosis to pelvic incidence, something that we have to take into account when we're planning all of our surgeries. Of course, there's the sagittal balance and also the pelvic tilt. So, pelvic incidence is obviously a very important driver of our lumbar lordosis. We're all born with a certain amount of pelvic incidence, and that stays constant throughout our life. As time progresses, we may lose our lumbar lordosis, and we have to conceive of our constructs in a way to try to get the lumbar lordosis to be roughly similar to the pelvic incidence, plus or minus 10 degrees. Pelvic tilt, as you can see, is is depicted by this purple line in the figure, and that's the line relative to the femoral head going straight up relative to the same line that you use to measure the pelvic incidence, which is that perpendicular line to the vertical line depicted here in red. Oh, whoops. So we have a variety of treatment options in the treatment of patients with scoliosis. And probably the gold standard is just open standard surgery. There are advantages and disadvantages to standard open surgery. Disadvantages are the lengthy recovery process. Advantages is the visualization of the anatomy and the better opportunity for arthrodesis. We have adopted MIS techniques that Jeff Rowe discussed earlier, and there are hybrid procedures which are becoming increasingly common, taking the best of all worlds. And we're going to go through several cases that sort of go through the decision-making process of what the surgical goals would be and what technique is used in different cases of adult scoliosis. So patient selection plays a very vital role in the management of adult scoliosis, and these are not the kinds of patients that you want to sign up for surgery in your first clinic visit. These are patients that you need to see on regular intervals and perhaps get to know them over the course of several months before you sign them up for surgery. You really have to know whether or not they're patients that are going to follow up. Do they have a reasonable life expectancy? And is the patient capable of understanding the risks involved? Because as we all know through Dr. Chapman's lecture earlier, the complication rates for these large deformity surgeries are quite high. So these are the grades of destabilization, and we'll go through different case scenarios discussing various grades of destabilization described by Schwab from 1 all the way to 6. The use of wedge osteotomies in the United States is increasing significantly, and this again correlates with our increased knowledge of sagittal alignment and the need to perform corrective maneuvers during surgery. So we're going to progress through several cases and go from maximally invasive to less invasive and discuss the reasoning for the different selection of surgical approaches. So this is a 51-year-old with worsening kyphoscoliosis. She has had a 2-stage anterior-posterior correction of her kyphoscoliosis in the past. But she developed with worsening pain in spinal alignment. So as you can see, she has a significantly positive sagittal balance. She has an inequity between her lumbar lordosis and her pelvic incidence. And this is a situation where she's had previous anterior instrumentation in the lumbar region. And so first line of logic in this patient was that she needed to have that anterior hardware removed in order to regain flexibility of the lumbar spine. So that was stage 1.
How did you do it, Charlie? Big open?
Yeah, a big open procedure. Basically using the same incision that she had, and this was with a vascular surgeon. So now that the hardware has been explanted, now we sort of have a somewhat normal case where we can think about our pelvic parameters and sagittal alignment. It turns out that she had the need for about a 40-degree correction, and the plan was to perform a extended PSO. But with this patient's significant surgical history, she ended up having significant loss of CSF from a bad durotomy with significant blood loss, and this required staging just due to the massive blood loss encountered during surgery. So stage 2 was basically resulted in this with the securing of instrumentation distally, the initiation of the osteotomy, and the encountering of the CSF leak with significant blood loss. Neurologically, she remained normal, but we decided to do the rest after she could be resuscitated. And so finally, stage 3 consisted of the completion of the osteotomy with the development of this correction and normal sagittal alignment. This patient is 5 years post-op and is doing quite well and is happy. So this is a maximally invasive case where you had to use all of your tools in the toolbox to get this patient aligned sagittally. As you can see, she had these old laminar hooks, and we preserved them. We were able to make use out of those nice cortical planes, and it was very solid fixation. So we'll move on to this patient. This is a 59-year-old with a previous history of a T2 to iliac fusion. She developed a pseudoarthrosis at L2-3 with a solid fusion distally. The referring doctor decided to remove the distal hardware and perform a 2-3 lateral interbody fusion. Initially, the patient did well, but then started to develop progressive kyphosis and sacral pain, and she also developed signs and symptoms of cauda equina syndrome. And so, as you can see, the patient had a positive sagittal balance. She had a significant loss of lumbar lordosis, and very importantly, she also had a bad sacral fracture. So, this was the etiology of her cauda equina, and so she needed several things to be addressed. Not only the sacral fracture, but also the lack of lumbar lordosis, and she ended up having a 3-column osteotomy, and this is the final result with a restitution of her lordosis. And over time, due to the pelvic fixation that was performed, she had, this is her 24-month post-op films, and over time the fracture did heal in a very satisfactory manner.
Did you try to repair that non-union or that fracture?
In the pelvis,
Yeah.
or in the sacrum?
Did that just heal without any type of like?
Just with the pelvic, the pelvic fixation. She had a 1/4-inch system. It was a very rigid fixation, and it did the job. So far we've discussed maximally invasive. Now we're going to move on to minimally invasive. So this is a 52-year-old physician. She was well read and did not want a large open surgery, and came in wanting to have a minimally invasive procedure. And so, as you can see, the focus of her problem, she had primarily right-sided leg symptoms, and you can see that she had some degenerative scoliosis, and the focus of her issue was at the 3-4 and the 2-3 levels, and so these films demonstrate that she had some foraminal narrowing, but did not have central stenosis. And so a large open procedure really wasn't needed for this patient. She had some disc space collapse, more so on the right side at 2.3 and 3.4. And so this was an ideal candidate for a trans-psoas lateral approach with percutaneous fixation posteriorly, and she did very well and is back to work and is quite content. So, so she had preservation of most of her motion segments, and so far hasn't needed anything. I think she should be about three years post-op now. This is another physician, a 74-year-old who had a profound positive sagittal balance. In addition, he had a lateral deformity with some olesthesis. And as you can see, this patient was significantly compromised with his ability to walk due to his imbalance, was requiring a walker at all times, and was having severe pain and was starting to develop some atrophy in his musculature in his legs. This being a 74-year-old physician, I wanted to try to design a surgery that would be associated with minimal blood loss. So this was another case where, in this case, we ended up using the OLIF, the oblique lateral interbody fusion. And as you can see, we didn't try to do a complete correction. He had a spontaneous fusion between 5.1, and so we ended up doing a small segment fusion, or short segment fusion, and you can see sagittally he's significantly improved. It's not a complete correction, but he's very content. Coronally, he's back to fair neutrality.
On that one, it looks like you guys were responding at 4.5. Are you concerned that he's got a union on both sides of responding?
So he was actually, I said that he was fused at 5.1. He was actually fused from 4 to 1. Yeah, good point. So this is a 55-year-old who has never had previous surgery, but she was having progressively worsening back pain and leg pain. She had these pelvic parameters. She was lacking a significant amount of lumbar lordosis, and as you can see, she has some evidence of gas within the disc spaces at 2.3, 3.4, and 4.5. So initially, I thought about doing a lateral followed by posterior fixation in her. In discussion of this thought process with her, she realized that this would be two different surgeries, and was a little bit apprehensive about that because she had obtained other opinions from other surgeons in the community who said they could do it just in one procedure through the back. And I certainly said that would be something that we could explore as well if that was her preference. And so that's what we did. So we ended up using these disc spaces with gas in them as the sites of her spine that would be mobile, and focused on the ones that had the greatest amount of disc space collapse. And as you can see, there was an asymmetry in that disc space collapse. And so this is one of the situations very similar to Dr. Chapman's talk earlier, where an intradiscal expansion and a thorough discectomy was performed in order to expand the anterior height of the anterior column and to then provide posterior shortening through posterior column osteotomies. So as you can see, we chose to do this in an asymmetric fashion and achieved improvement in her deformity. And as you can see over here, coronally she was significantly improved. And sagittally, you can see that there, in comparison to the left, you can see improvement in the anterior height and the overall lordosis, and sagittal balance has improved significantly. So, bottom line is there are a variety of different ways that one can go about addressing sagittal imbalance, and depending upon the severity, one may need to implement minimally invasive strategies versus large open procedures, as demonstrated at the beginning cases, which were more complicated, and so we need to tailor the surgical plan to the individual needs of each patient. For instance, the older patient, the 74-year-old, we really wanted to choose a surgery that would provide him with minimal blood loss. So I know Seattle's a beautiful city, but according to this bench, Baltimore is the greatest city in America, so you should come for a visit. Yes, Dr. Dubasset. Thank you.